And together and with passion, we are intensive care medicine.
I'm so proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
I am a hepatologist and an intensivist, and I am proud to be an intensivist. We are intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
You are now in the corridor.
Your suggestion.
The CAM ICU score.
Of the facial mask is
The system that we use.
to really be immersed.
Hello, everyone. My name is Adrian Wong. I'm one of the members of the ESICM social media group covering lives today, and I'm joined by my friend and colleague.
Hello there, everyone. My name's Shagan Olusanya, and I'm also one of the social media team covering ESICM Lives 2020 with Adrian. It's a pleasure to be here.
Okay, now this has been branded as the social media update debrief. We're about 3/4 away through day one of Lives. We obviously had the opening plenary yesterday. And straight off the bat, I would just like to say a big shout out and thank you to the technical support team who have been working very, very, very hard behind the scenes to make this all possible in our new digital event. Aman, his team, and Sim team have done an amazing job. You have no idea how stressful it is.
It's been pretty seamless,
Sagan.
hasn't it, mate?
It is, isn't it? What me and Sagan were going to do was we were going to go through the program and just highlight a couple of discussions that's been happening both in the digital world and the even more digital world of Twitter and social media. So Sagan, anything caught your eye today so far?
So just looking at today, I mean, we've already had a nice chat about yesterday in the opening ceremony, but looking at today so far, the biggest highlight on social media appears to have been Prof. Herridge's chat to aspiring intensivists, which was apparently inspirational, motivational, really moving, really touching, and really balanced. She gave a really human description of what it's like to be a cutting-edge intensivist. And so far, that's been buzzing in all my feeds. I don't know what's been going on with you, mate.
I really, really enjoyed that one. I have to admit that I wasn't one that I earmarked to listen to, but following the noise that's been generated on social media, ducked my head in and caught most of the interview that Professor Herridge spoke about, and it really resonated with me. She is someone that I immensely respect, having watched her speak at several conferences. She's an excellent speaker, authoritative speaker. But I think the session today just made her a bit more human. I think there's often times that we, certainly for someone like me, I put myself up as someone who's not the sharpest tool in the box. I don't have academic prowess like all these big names, and she's someone I aspire to. But it's really nice when she talked about the challenges, her day-to-day lives. I think she mentioned her 3 kids, and actually said it made it a lot more human for me.
And I think that's been a big feature throughout this conference so far. I mean, I appreciate this is day one, But already
Mhm.
from the start, there was a huge amount of discussion about the human aspects of intensive care. And I wonder perhaps the
Mhm.
COVID-19 crisis has actually brought that to the forefront. And all of us are remembering how fragile and vulnerable we are, as opposed to being these amazing super docs who publish 20 papers whilst, intubating and resuscitating everyone and measuring every parameter in the book and performing perfect, optimal, numbers guided resuscitation.
And I think that's on that note, I think it's really nice because the session I was listening to just before joining in this one was the session organized by our Nursing Allied Healthcare Professional Committee. Big shout out to them. It is an amazing program they put together so far. And this talk that I was listening to was Professor Ruth Kleinfeld, who we all know as a recent past president of the Society of Critical Care Medicine USA. And she was talking, as you've shown on the screen here on the Twitter feed, about resilience and how reducing burnout. What's interesting about it is that I don't know whether it's comforting or not comforting that the burnout problem, resilience problem, well-being issue is international. It's not just UK intensive care. It's not just Italian intensive care. It's not Spanish intensive care. It's not just the doctors. It's just the nursing staff. It's not just the allied healthcare professionals. It's across the board. And although this is an intensive care conference, I suspect if you were to extend some of these challenges and findings to other specialties who've had to face this, respiratory, cardiology, almost every single specialty out there, I think those issues would be common ground.
I can't agree more. I think this has been a real rallying cry about something that, again, with conflicts of interest to declare, you and I have been talking about this. We wrote our first paper on burnout was written together in 2016. Is that right?
I can't even remember now.
I think it was
this year has gone into slow motion, I think.
Anesthesia. And since then, we've both ended up, I've ended up being on the National Wellbeing Committee for the UK Intensive Care Society. And for a little while, it almost felt like you were screaming into a void. And now everyone has woken up and taken notice of it. And it feels like I
think it's really nice that, it's taken a global pandemic to actually make it okay to say you're not okay. But the noises and movements were already there. I know the ESICM, when during Ruth's tenure as the president, was already working towards the well-being of intensivism. I remember when she launched it, I think in a conference in Hawaii, I think it was. And that was a rallying cry.
Remember that big paper, the call to arms?
Yep, it was a call to arms. They put it up, the UK picked it up, the ESICM picked it up, but it was always there and it was always going to happen. By the way, people, if you've got any questions, comments, or anything like that, please feel free to use the chat option. I've been reassured that I'm using it the right way, but we will see. I happen to have had questions and suggestions already messaged to me directly, which I hope to cover later on as well. Just rounding off the subject on that nurse and allied healthcare professional session, which was highly, highly, highly recommended. Margot, who is one of the members of that committee, has recorded a very, very nice podcast with me earlier today, which we hope to get out later on this evening.
Yep, look out for that on the blog. And there's already quite a lot of good stuff on the blog so far. So I noticed that you put up some really interesting stuff on the session on updates in anesthesia, respiratory, and cardiology.
That was going to be, so I watched it late last night, early hours this morning. And again, it's on the video on demand. Just again to mention, there are 90 hours of video on demand available on this amazing repository. And one of the highlights, one of the talks that sort of jumped out at me was Mythbusters, but also this session on updates from the various specialties we work very, very closely with. And they included people like Susanna Price talking about cardiology. There was an update from a respiratory consultant colleague from the
Mm-hmm.
Netherlands talking about interstitial lung disease, a neurologist who talks about COVID and neurological symptoms with COVID. So yeah, I thought, and our anesthetic colleagues as well, talking about how do we work together in partnership in trying to improve outcomes for our surgical patients, certainly the perioperative management group. And we have a committee here in the ESICM. That concept is being taken further and further ahead in order to improve patient care.
And I was reading that last bit, the management of the perioperative patient, and it really got me thinking. And I don't know if it got you thinking as well. So there was this talk about minimizing starvation times and using carbohydrate loading, et cetera, et cetera, et cetera. And yes, there's a big push to that for the elective patient. But then I was just thinking about, what about my ICU patient who's NG fed, and then we stop the NG feed at 6 o'clock for an operation that happens at 3 o'clock that afternoon, and they also get decarbo loaded, et cetera, et cetera, et cetera. Should we be thinking about applying these perioperative optimization principles to them as well?
It's a very good question. I have to say, you and I both worked in several different hospitals, admittedly within the UK. So if the experience is different in other parts of Europe, please send us a message and let us know what the practice is. But there seems to be a discrepancy between the patients undergoing emergency surgery versus elective surgery. There are obviously going to be differences, but from your perspective, the planned return to theatre, which I think is what you're talking about, they seem to get a slightly different feel and priorities. And I'm not sure why that is.
But it's not even just the planned return to theatre. It's sometimes the the emergency, the ITU patient that suddenly develops an acute abdomen, and that wasn't, So as I worked in a unit with cardiogenic shock, and that kind of stuff is not that uncommon. Somebody having acute ischemic bowel, and have we, is there a role for looking at some kind of acute, the perioperative optimization of the acutely unwell ICU patient? And I don't know. I don't have any answers. I was just throwing it out.
That's a very good point. And I suspect what the people to us is the members of our perioperative interest group within the ESICM itself. So we shall find one of them, drag them down, and get her or him to help us answer that question.
That would make a great interview, I think.
Okay, moving on to the session in the morning, I'm very keen. I mean, I know Aman, who's organizing this conference, was very, very keen on the interactive component within the conference itself. Hence, I went to the case-based fundamental sessions, which I've just shown on the screen here, which happened this morning, chaired expertly by Lenny and Frankie from Utrecht and Prague. And it's a very, very nice idea. And I was just keen to see how it would work, given that lots and lots of people were probably going to be interested. How do you moderate such a busy session? But I suspect it's done really, really well. So anyway, just for those of you who didn't tune in or tune into bits of it, the case-based fundamentals were essentially a series of sessions where you discuss a case, and you then had a series of learning objectives. And the case was there to help you illustrate, dissect, and discuss these learning objectives. So and there will be several of these as on day 1, day 2, and I think on the last one on day 3 as well. But today's one was the classic septic shock patient. What would you do? I can't remember the details of the exact details of the patient now, but essentially it was someone who's come in with a pneumonia, a low blood pressure, fevers, tachycardic, low saturations. We've all been there, done that, I suspect.
Yes.
And then we move towards what fluid do you use? And inevitably, the controversies around fluids were discussed. And so, as you can imagine, there was a wide range of opinion. And what was really nice was that the interactive component of the talks, be it through voting or through the chat, and also through the Kahoot function later on, highlighted the variations in practice. Thoughts on initial management with fluids then, Sagan?
Am I the right person to ask? Again, massive conflicts of interest. I work with you on IFAD. I was one of the authors that wrote a paper led by Rory Spiegel, aka EM Nerd on Twitter, about how the surviving sepsis guidelines should be challenged. So I mean, look, what fluid is pretty straightforward right now. All of the evidence and all of the supporting data supports balanced crystalloids as being your first line. They probably cause the least amount of harm. The ultimate, but then I also side a little bit with remember the very famous quote by Malcolm Fisher from Australia? I don't care if, what fluid should you give. I don't care whether you use dog's urine as long as you use it carefully. So there's probably an element of that.
Infamous quote.
Absolutely infamous quote. But beyond that, I think rather than looking at which fluid, because really in your first instance, it's not necessarily about what the fluid content is. It's probably more about how much and what rate and what your stop points are. And also rapidly recognizing whether this patient has fluid responsive or fluid non-responsive shock and using appropriate markers to identify that. I think that's probably more of the question to ask. I don't know what you think.
I think that we could spend hours, days, months, years deliberating fluid. But I thought what was interesting in that series of case-based fundamental sessions, which took up the entire morning, was the variation in practice. I think the people seem to appreciate the big headlines, but when it comes to the nuance of what you would do by the bedside, yes, you could do this, yes, you could do that, but what is it that you would ultimately do? I found a variation in practice from the responders and attendees of that session, both reassuring and worrying in equal measures, I suppose, because we've all seen the patient who comes in a bit hypotensive, a bit tachycardic in all our intensive care units, be it in Belgium, be it in Netherlands, be it in Spain, be it in Italy, etc., etc. The evidence is based on the papers that are accessible. We've all read them. If you choose to use a guideline or a protocol or what have you, certainly the international ones from the Surviving Sepsis Campaign, just an example, is also freely, openly accessible for people to process, digest, tweak if they so wish, and ultimately implement. And the fact that there's still that variation is to me a lot of food for thought, because I suspect, or I hope, that in terms of so what now and as a way moving forward, is how do we translate best practice as dictated by our most up-to-date evidence from the trials, the research, etc. How do we take that information there and transfer it to the bedside, and not just to the bedside in a day or two or by a few different individuals, but how do you do it across the board of your intensive care unit, 24 hours a day, 7 days a week, irrespective of which consultant, junior doctors, fellows, trainees, nurse, allied healthcare professional? How do you take that best practice and implement it on a consistent basis? And that, I suspect, will be I hope will be a recurring theme and point of discussion moving forward in this conference, but also in future conferences as well.
I think you're absolutely right. I think that knowledge translation, and yes, it's very difficult because we appreciate that at the moment it's very difficult to define exactly what best practice is. We currently have a set of guidelines. We have a set of papers that suggest benefit from balanced crystalloids over normal saline. We have some papers that are suggestive that a conservative approach, but nothing is fully set in stone. So at some point, individuals have to almost stick or twist. They have to decide for themselves, what am I going to do for my unit, for my patient population, kind of almost set that in stone and say, this is what we as a unit are going to do, and then revise that revise that constantly as new evidence comes into play.
and I like that. I think that's a challenge to intensive care, not just the physician side of intensive care, but the intensive care team itself. Because whatever improvement, change that you are going to do, you are going to need a team. You're going to need the whole team behind you, and you are going to need the leadership to set the example, if you will, set the tone in order to achieve those changes. But I sincerely hope we'll get there for all sorts of manners, not just for fluids, obviously.
Yeah, I really hope so too. I think there's lots of things in ICU that could do with some degree of, I know it's a horrible word to say in the age of individualized and personalized medicine, but some degree of standardization, perhaps. You standardize and individualize at the same time. Is that possible? I don't know.
Again, I suspect that was a conversation piece too that will take weeks, months, years.
Absolutely.
The master side of things. Okay. Anything else caught your eye on day one that you want to talk about? I sort of moved it up to the lunchtime agenda already.
Absolutely. So so far on day one, the other things, I guess, being, me having my interest in cardiac, listening to, seeing Susanna Price talk a little bit about the updates in cardiology, and the new hotness now for this cardiogenic shock and mechanical support and its place and all those kind of things. So that's all very new. Well, not new, but talking a little bit more about it, and trying to recognize that cardiogenic shock is an emergency, like septic shock or anaphylaxis, and that getting people to some form of, not just sticking some inotropes down and hoping for the best, but actually targeting some form of cardiac index, cardiac output, and mechanical support, some kind of ventricular unloading as a whole, and taking that forward. That's a relatively new concept for lots of people, and I don't know. I thought it's always quite interesting to read about that. I don't know how interesting you found that.
I think so I'm not an ECMOologist. I do have colleagues who are ECMOologists, and I find the physiology and decision-making process that surrounds ECMO circuits, decisions, etc., fascinating. But it appears to me it's like most things in intensive care, it's about balancing the risks and the benefits, and individualizing the risks and benefits to that particular patient. And ECMO, to me, and this is my personal opinion, is one of those therapies where you think it's amazing stuff. Obviously, it changes, it saves lives, so on and so forth. But that's on the provision that you've got the right patient. And more, I think, in healthcare, we have learned that whatever we do, be it from the very, very invasive ECMO lines and as a therapy, to the other extreme, to perhaps putting in something as mundane as a central line, does come with risks, does come with potential harm. And one of the things that resonated very strongly, and I remember it now because you talked about the harm side of things, was Professor Harris again mentioning in her work in follow up all these patients post-intensive care, was the question how much that patient is prepared to sacrifice after the intensive care unit stay, because she feels quite strongly that we leave them with a degree of disability, be it small or major. It does happen. There is almost like an exchange, and that exchange could be physical, it could be mental, cognitive, psychological. That may not be fixed in hours and days after leaving the ITU. It may take up to years for people to recover. And the very, very powerful and moving story by a sepsis survivor from, again, the Nursing and Healthcare Group session this morning was very, very powerful in reminding us as healthcare professionals of what we put the patient through.
And that's a really powerful point. And again, that has been touched on with sessions earlier today on the admitting the frail patient to ICU, the pros and cons of that, and the decision making around that, and even more so, admitting frailer slash more challenging patients to ICU in a time of a pandemic with diminished resources, that brings about a huge bunch of ethical, moral decision making that perhaps we weren't trained for, but we certainly have to embrace at the moment. And it still comes back to that point of what is ICU for? What is our actual aim to do? What is our shared goal with the patient and their family? And what is an acceptable outcome? And these are all huge, massive questions to ask. And it does make me think, should we have consent forms for ICU admission while we talk about all of these things and all of these risks?
Provocatively, that's the question I raised, and after hearing that patient story was do you think we should consent patients when we obviously when we see patients who are critically unwell and their families are worried about their loved ones, we talk about coming to intensive care unit, they're really, really sick, they might be put on a ventilator, we'll put in drips, lines, so on and so forth. We obviously mentioned death, and we mentioned the morbidity, they might be left. Do we need to then talk about the psychological component? Because that was at least to me anyway, the overriding lesson from that patient story, which was he was left with significant post-traumatic stress disorder, which wasn't really diagnosed until 6 months later, something like that, I think, in his talk.
Yeah, that's so. When I think about consent, the thing that I think about, you for some of our international viewers, you may not have been aware of the case of the Montgomery case in the UK, which has profoundly changed the way that we consent things for, in that we had a patient was not consented for a certain aspect of her care, and she took the trust to court and she won. And so now in the UK, you are mandated by law to ask people and let people know about all the risks of everything you do, regardless of how small it is and whether you think the patient deserves to know or not. And just touching on that just makes me think that I think you are right. I think we should possibly have much deeper discussions about the implications of ICU and its aftermath. But again, that's probably a whole conference in itself. Okay.
I think we've got something like 5 minutes left on the clock. So hopefully this recording will be available later on. We're going to hopefully convert it into a podcast as well. So if you've got any comments, feedback, anything you'd like to see, anything you don't want to hear, please let us know. It's an experiment for all of us. It's a new experience, a new format for all of us, and very, very open to suggestions. So what are you looking forward to for the rest of the day and into day 2 then, Sagan, as a way of wrapping it up?
Well, the big thing that I'm looking forward to later on today is actually the grumpy old men conversation. So,
for those of you who don't know what we're talking about, is that one there?
Yeah, okay. So I think hopefully Adrian's got it up. And so Jean-Louis Vincent, Jean-Daniel Chiche, and who else have they got? Jan Bakker.
Yeah, Yuka Takala will be there on tonight as well. So a collection of Statler Waldorf comments from past president. Yes, I'll be watching out for that. They're always good value. And me and Sagan and a couple of other people might provide alternative commentary if we value our career. We might not, but we'll see.
That would be quite interesting, because they're meant to be quite irreverent, and so if we're even more irreverent, that might be quite amusing.
So make sure you tune in for that one. Tomorrow we've got another one of these social media debrief sessions, and we'll be joined by a very, very special guest to discuss all things intensive care and the conference as well. But I think we're close enough to time, so we'll call it a day.
Absolutely. Yeah, I think call it a day there. Oh, just to let everybody know, we've potentially got an interview with Glenn Hernandez coming up, so look out for that on the blog tomorrow.
Correct. We're going to talk to Glenn later on this evening about all things cardiovascular and obviously the Andromeda trial.
Fantastic.
Cool. Right. Excellent stuff. Take care, everyone, and we'll speak soon.
See you all later.
Four months ago, intensive care changed for good in the way it is carried out as well as how it is perceived. COVID-19 was of course the catalyst, and it has dominated our work, overshadowing all we do. We are still fighting this virus and still working day and night to help all the patients in our care. But what has been achieved during these exceptionally trying months is something we should all be proud of. The European Society of Intensive Care Medicine has proven a valuable resource for those who have the power to change the status quo in healthcare across the European Union. During this time, European Society of Intensive Care Medicine has strengthened its connections with EU health, education and finance ministers, as well as EU policymakers at the European institutions. We are pushing hard for the free movement of intensivists so that we are able to work in all EU countries and for our speciality and competencies to be recognized throughout the EU. We are gaining serious momentum, and media around the world has been echoing our call for an army of intensivists to fight COVID-19 and future pandemics. But it doesn't end there. Our society has responded to a global need for expertise in our speciality. As we all learn and gather data about the virus, we have made it our purpose to facilitate the sharing and dissemination of life-saving information to not only our members, but also to the medical community worldwide through a series of COVID-19 dedicated webinars reaching hundreds of thousands of individuals in over 60 countries. And that's not to mention the numerous resulting studies, surveys and other global collaborations. Unite COVID-19, for example, the one-day point prevalence observational study designed to discover more about the burden of the virus in ICUs across the world. So far, 260 centers have signed up, and registration is still open.